Okay, it looks like it's slowing down a little bit with folks joining the room. Welcome. I am Dr. Shannon Dowler. I'm with the Office of Infectious Disease and HIV/AIDS Policy. Thank you so much for joining us today on our second webinar of the Stopping Syphilis HHS Summer Seminar Series. Today, we are going to dig deep on one of the newest tools in combating syphilis in our toolbox, the point-of-care tests that are relatively new to the market. Before we begin, I do want to say at any time, if you need technical assistance, you can do two things. You can contact Jennifer.Adona, A-D-O-N-A, at HHS.gov, or you can just chat with the meeting host. As a reminder, please be sure to mute your microphones. Let's see. All right, before we get started, I want to note that the considerations for syphilis rapid point of care testing document that we're going to be referencing today was developed and released by the HHS National Syphilis and Congenital Syphilis Syndemic Federal Task Force, which was launched and chaired by Admiral Rachel Levine. It's important to note that the information presented in this document doesn't actually represent the official position of any specific federal agency. In the deck for this presentation, you're going to actually be able to click on this and it'll take you to the document. So you'll have access to that document when we're done. So we have a full agenda today. We're going to be talking with two experts in the field, Dr. Phoebe Thorpe, who led the development of the point of care testing considerations document, and Dr. Stephanie Taylor, an infectious disease physician, academic faculty, and public health leader in Louisiana. And as a bonus, before we shift to question and answers today, we're going to share some updates on Vicillin. But before we get started, let's find out who's in the room. Throughout the webinar, we're going to use audience response questions to help keep us all engaged and paying attention. Don't worry if there's a question you don't know the answer to. It's completely anonymous. No one will know how you answered. So let's launch our first question to find out who is in the room with us today. So it's possible we did not get every professional category of human beings that could be with us today, but we tried to get the majority. So which of the following categories best describes your professional role as it pertains to syphilis? Are you a clinician that's doing direct patient care? Maybe you're a clinician, but you're really in the background reviewing and signing off on the works of others. You could be support staff, outreach and education, disease intervention specialists, my favorite people, an administrator, a funder, a payer, a public health professional, or maybe you're a Greek scholar and you thought this was a Sisyphus webinar, not a syphilis webinar. Let's find out what folks said. Let's see, Damon, you got, there we go. Oh, wow, what a great spread of different people that we have in the room today. This is fantastic. So lots of public health professionals, and then we have some clinicians as well, our DIS folks who we could not manage syphilis without, and a couple of you that are clearly thought you were in the Greek webinar. That's okay, it'll still be fun for you. All right, as we launch the next question, let's get a little bit more into syphilis brain. So, question 2. This one has a lot of different options. So when it comes to syphilis testing, which of the following best describes the type of setting you're currently providing testing for in your office? Now, I know not all of you are clinical, so at the very end, you can choose does not apply, you're not clinical. But if you are clinical, are you doing dark field microscopy? Because if you are, I really want to come visit you and see those spirochetes. Maybe you send all your tests out to another lab. It's possible you do in-house testing. Maybe you're a hospital or in a health system, but the results take hours to days. Do you do stat RPRs in-house, but then you send out your confirmatory results? That's what I do in my inner city health department. Maybe you're already offering rapid point of care tests and you send out your confirmatories. Maybe you do it all. Maybe you're doing those point of care tests, stat RPRs, and sending things out. It's possible you're not currently offering syphilis testing, but you're interested in it, or you're not offering syphilis testing and you don't plan to. So let's see what folks say in the room today. All right, lots of options here. Nobody's doing dark field. I'm so sad. I was hoping to do a site visit somewhere. All right, so a lot of people here are sending out all of their test results, and that's a very common response. If you're not in a sexual health clinic, then it's very possible that everything goes out and you don't get your results for a while, which honestly can be part of our challenge. Okay, so digging in specifically to the point of care test, we'll get to our third interactive question around the point of care test. Which of the following describes your current level of experience? Are you someone who has a lot of experience using them? Maybe you just started. Maybe you're not using them, but you'd like to. It's possible you have no plan to use them, or you're not in an environment that offers testing at all, or maybe you're just here for the audience response questions. So which of these best describes the point of care test experience you've got? Damon, let's see what people say. All right, a mix. So a handful of you out there have a lot of experience. That is fantastic. We're going to look forward to your input as we go through this slide deck and our training today. You're not using them, but would like to. I think that represents a lot of folks out there. And I hope by the end of this webinar, you're going to feel really comfortable about launching in and using them. All right, let's see here. So today we have some objectives of the webinar that I've been through with you briefly, but understanding how to use these Syphilis point of care tests, what setting is best, and look at effective considerations that you should be thinking about with implementing them. And we've got a little sneak at the end around treatment with bicillin. So before we shift over to Dr. Thorpe, who is going to go in deep on all the knowledge that you can get in our point of care considerations document, we do have a couple more questions for you. Damon, let us ask how people actually feel. This is a safe place. You're with friends here. We all care a lot about syphilis. Which of the following best reflects your feelings about interpreting positive syphilis test results? Some of you may be really comfortable and experienced with it. Some of you say, well, I don't order them, then I don't have to worry about positive tests. Some of you might say, I'm pretty good at it as long as I got that CDC website. Some of you feel like it literally wrecks your day. I think that's particularly true of people who only see positives every now and then, or maybe you don't interpret syphilis test results. How do people feel about positive tests in this audience? This is great. So only a few of you feel like it really wrecks your day. I find that a lot of people have that feeling, so that's wonderful. I like that a lot of you, almost 30%, are comfortable as long as you've got that CDC website handy. Fantastic. Okay, last question, and then Dr. Thorpe is going to enlighten us. Our last question for the day, as we get into the point of care testing, which of the following people would not be a candidate for the syphilis point of care test? Someone with a substance use disorder that's in a recovery program, someone being admitted to a correctional facility, someone who is historically not trusted or engaged in healthcare, someone who is uninsured and without a primary care provider, or someone just treated for secondary syphilis. One of these people isn't the best candidate for the point of care test. So let's see what people had to say about that. Amazing, wonderful. So fantastic. As you can see from the results, if someone who has already been treated and been infected with syphilis, unfortunately, we're not going to be able to use this test in the same way as somebody else. So with that, I'm going to move us over to Dr. Phoebe Thorpe. She is the co-chair of the Prevent, Screen, and Diagnose Subcommittee in our National Syphilis and Congenital Syphilis Syndemic Federal Task Force. Take it away, Phoebe.
Thanks, Shannon. And I am so excited with those results. Thank you for those questions. It gives me wow, 97% know the answer already is great. Shannon did allude to the fact that I am doing a little bit more of the technical stuff, just as a forewarning. And I am Dr. Phoebe Thorpe, and for inclusion purposes, I have reddish hair, I'm wearing glasses and a white jacket, and I am very pleased to be presenting on behalf of the National Syphilis and Congenital Syphilis Syndemic Task Force. As you well know, syphilis rates have skyrocketed, and the need for testing, including point-of-care tests that could provide rapid results, is necessary. I will cover the considerations for implementation of syphilis point-of-care testing, the document that was created and posted by HHS in June. I do want to say that I owe many thanks to my colleagues in the Division of STD Prevention at CDC, members of my subcommittee, and the task force for their collaboration and support on this document. In addition to having a clinical focus, there are public health and program considerations too. And then just as a reminder, Dr. Taylor from LSU is following up with lessons learned and other practical information gathered from her experience. So briefly, my agenda for today is, sorry, can you go to the next slide? Help provide oh, too far. All right, sorry, they must have taken that one slide out of my deck. That's okay. I'm just going to provide a brief overview of diagnosing syphilis and then move on to the advantages and challenges of the point of care test, and then give some examples where implementation of the point of care test might be helpful. Briefly, diagnosing and treating syphilis is a combination of recognizing the symptoms, looking at test results, knowing your prior medical history, sexual history, and potential exposures. If signs and symptoms are present, the diagnosis and treatment can be pretty straightforward. You order the tests for further management and offer treatment on the same day. You also have to counsel the patients. However, if there are no symptoms, the diagnosis is less straightforward. In addition to asking about their sexual history and possible exposures, the clinician has to order lab-based treponemal and non-treponemal tests, which return after the patient has left often. If the test results are positive, then the provider needs to review the previous history, labs, and determine if this is a new or previously treated syphilis infection. And if it's new, then they have to ask the patient to return for treatment. But what if the results were available the same day? There are 2 point of care tests for syphilis available for use in the United States: the Syphilis Health Check and the ChemBio DPP HIV Syphilis Dual Test. Advantages of these tests include that they are a finger prick, which is much easier to collect than venous blood, and the results take 10 to 15 minutes, allowing patient treatment to be provided at the same visit if they're positive. Here is, this shows how the syphilis health check is performed. You prick the finger, use the pipette to collect the blood, drop it in the well, add the drops, you wait 10 minutes, and you have the test results. This one illustrates how the ChemBio test works. It's a similar finger prick, adding drops in 2 steps, waiting 15 minutes, and then on the right side of the slide, you'll notice one difference. ChemBio has developed a reader, the blue little gadget in the person's hand, that helps interpret results. However, these tests are fast. However, there are some limitations, which means they cannot be used for everyone and in every situation. Drawbacks include the current point of care testing provide only treponemal results, which, as you know, indicates an infection at some point, but does not distinguish a new infection that would require treatment from a previously treated syphilis infection. Non-treponemal titers are used in disease management, and they're not available as a point of care test. This means that if the point of care test is positive, in addition to assessing the person, non-treponemal titers need to be ordered. What this also means is that the point of care testing cannot be used to screen those who were previously treated for syphilis, because the point of care test will likely be positive, but not show a new infection. Another reason is the test performance. That is, the sensitivity and the specificity of point of care tests are lower when they're used in the field than when they're used in labs and compared to lab-based tests. And just as a brief reminder, low sensitivity means that those who have syphilis will test negative and we will miss opportunities to treat them. Lower specificity means that those who do not have syphilis will test positive, which can lead to overtreatment. Let's take a look at the actual numbers on the next slide. This chart shows sensitivity and specificity for the point of care tests in the field at the top and the routine-based testing on the bottom. So the ChemBio is on the top line, and then the Syphilis Health Check, followed by the lab-based tests, treponemal and non-treponemal below. In an analysis of the few studies available on point of care tests, they showed that the field use results in lower sensitivity and specificity compared to lab-based testing, as you can see in the blue and now turquoise columns. I would like to point out that lab-based testing is designed to use the treponemal and non-treponemal tests together and one after the other or serially, so that when the results are taken in their entirety, the lab-based test accuracy is quite high. We also know that environmental conditions in the field are not the same as inside a lab, and some differences could arise from this. We've also heard that anecdotally that point of care testing results can be more difficult to read, and this may be why the ChemBio test comes with a reader. Programs have implemented point of care testing have mentioned that ongoing trainings to ensure the results are read accurately and timely have really improved the quality and increased sensitivity and specificity of these results. And we recommend that a quality assurance tracking system be put in place if these tests are implemented. Another important step to remember in establishing a point of care testing program is that these tests are CLIA waived, and organizations will need to work with a CLIA approved laboratory to start this effort. Quickly, as a recap, the advantages of point of care testing are that they are quick results, they're easier to read, and they're easier to actually do the tests themselves, and the results are fast, so people could be treated on the same day, which reduces loss to follow-up. There are challenges, including potential misdiagnosis or overtreatment. Only the treponema test is available, and they cannot be used with those who have a previous history of syphilis. But with syphilis rates skyrocketing over the last decade, it's important to look for innovations and tools that could be used to detect syphilis and prevent its spread. So how do we maximize the benefits while minimizing the risks? Let me walk you through it. Here's a diagram to illustrate where point of care testing could be implemented and take advantage of the opportunities it offers. Let's start with the large blue circle, which represents areas where syphilis is spreading rapidly. Focusing our efforts on this high areas of incidence makes sense intuitively. These areas are where the populations are. Within those areas, there are populations such as those in the yellow circle, less likely to have previously treated syphilis, or in the green circle, facing barriers to care, where offering point of care testing could make a difference. This may sound a little bit like niche marketing, and it kind of is, but it reflects the different populations that are at increased risk of syphilis and need to be reached with testing and screening. Point of care testing creates this opportunity to test and treat on the same day. Let's look a little bit more closely at the yellow and then green areas. Where is there low prevalence of previously treated syphilis? As a population, cisgender women are less likely to have recurrent infections with syphilis, and thus they have low prevalence of previously treated syphilis. Some populations with currently high incidence of syphilis in their communities and low prevalence of prior syphilis include persons identifying as American, Indian, or Alaska Native, particularly women, and Black and Latino heterosexuals, particularly women. Returning to our diagram, the green circle represents those with barriers to care, of which there are many, we all know. Point of care testing provides the results on the same day and might allow treatment at that same time. That way, the person doesn't have to overcome the barrier to care twice to get the care needed. For sites that already have the capacity to provide treatment, point of care testing provides the rapid results to act on. For example, use in emergency departments or urgent care sites would allow clinicians to provide treatment while the person is still at the facility. This would be especially important if another STI is suspected, or the person is seeking pregnancy testing or seeking care while pregnant. Jails would be another place that point of care testing could be used to ensure test results and treatment are available in a timely fashion. And for rural areas and clinics, long travel time is often a barrier to care, and the use of point of care testing could allow same-day treatment and reduce loss to follow-up. There are other sites where care is provided and rapid results could be implemented to detect syphilis infection. Many who seek care at substance use and harm reduction sites are tested for HIV. Point of care testing for syphilis could also be added. And many shelters serve populations that are vulnerable and have a high turnover rate. I would like to pivot and cover some clinical considerations that are included in the document when point-of-care testing is positive. Asking about symptoms and sexual history can help determine the stage of syphilis and the length of infection, which determines the treatment course. If possible, a physical exam for signs and symptoms and an assessment for neurologic, otic, and ocular syphilis should be done. People with positive test results should be counseled that the point-of-care test results could be a false positive or reflect past syphilis infection, and they need confirmatory lab-based testing and follow-up. When possible, same-day treatment should be given based on the length of infection, and anyone with reproductive capacity should be offered a pregnancy test. What else would support or make point-of-care testing more effective? Looking for ways to overcome barriers to provide immediate treatment, including bisalin, especially if the testing is done in the field. The treatment should be provided in the field too, when possible. While it's not necessarily absolutely needed to make a decision to treat the person in front of you, a hotline or a warm line with syphilis lab and treatment history could be available to coach and help determine if treatment is needed. If we want others to engage in this work, we need to support their efforts to enter it. We need training and education of everybody involved: laboratorians, physicians, partners, the public health staff, and the community. In summary, point-of-care tests have some limitations, but can be used to augment and complement lab-based testing. Figuring out how to get immediate treatment when testing is positive is important. They do need a CLIA waiver, so that has to be started early in this process. Point-of-care testing should be implemented with a quality assurance plan for results and in collaboration with the health department and other partners. Point-of-care tests can meet people where they are and provide the care they need. They can be used to rapidly detect infections and create the opportunity for immediate treatment. It's a tool that we can use to reduce syphilis. Thank you.
Thank you so much, Dr. Thorpe, and for your leadership on the task force, and particularly your hard work on putting together the comprehensive document. It was a tremendous amount of work, so thank you. There are some questions in the chat. She'll be working on answering those questions, and we're also going to have an interactive time of answering questions at the end. So not to worry, questions will get answered today. Before we shift it over to our next speaker, let us have another couple questions about practical implementation. And I already see a question in the chat that alludes to one of these. True or false? So these are the easy true false ones. All payers cover the cost of point-of-care tests. Is that true or is that false? I have a feeling people are going to get this right. So what do we have? What are people saying? Is it true or is it false? Do all payers cover the cost of this test? Yeah, sadly, I don't think there's anything in the world that all payers cover. So it's really hard to have a blanket statement around coverage of this, but it's an important consideration as you're thinking about your funding mechanisms and how you could justify the cost of a point-of-care test. And so it's really important to talk to your state Medicaid agency to find out if they're covering it. For instance, North Carolina has come out and said that they're covering it in their state Medicaid agency. And so as you think about implementing this in your payer environment, make sure you know what your payers are doing. Important point. All right, next polling question. Another practical implementation. Anyone can run the syphilis point-of-care test as long as they read the instructions first. My IT husband could go out and order one online and start offering them at our neighborhood farmers market. Is that true or is that false? Let's see. These are a little bit of a giveaway questions because you just heard Dr. Thorpe say, got to have a CLIA waiver. So these are CLIA waived tests. So they do take a little bit of an investment to be able to run these tests. All right, with that, let's see. Damon, I've lost my ability to forward slide. So can you shift us to the next slide? And I would like to introduce you to Dr. Stephanie Taylor, who I've really had the privilege of getting to know through preparing for this webinar. She is the medical director at the Louisiana Office of Public Health in the STI, HIV, and Hepatitis program, a professor of medicine and infectious disease at LSU School of Medicine. So thank you very much for joining us today. With all of your lived experience in the point-of-care testing world, I will turn it over to you now.
Well, thank you very much, Shannon, and thank you all also for the invitation to be with everyone today. It is a pleasure for me to have this opportunity to share my experience with using the point of care testing. We have been using them for quite a while now. So just Dr. Thorpe just did a fantastic job in breaking all of this down. I did just want to mention a couple of things about the rapid test. One, I wanted to just show us or bring to our attention the trials, the clinical trial, one of the clinical trials that had an impact upon bringing the syphilis health check into use. And this trial was done in Uganda and Zambia, where less than 10% of women who were infected with syphilis were treated on the day they were seen. And as we know, in Africa and rural areas and other areas, these patients had to actually walk to the clinic, walk back, would not, may not be able to make it back in time at all for another visit. And so once this was implemented, the syphilis health check was implemented, 90% of women were treated on the day that they came to the clinic. And so that was just a great success and tremendous, and had a tremendous impact on being able to now, on this test coming to the market. And now, as Dr. Thorpe mentioned, we have the dual rapid syphilis and HIV testing. And once again, what I wanted to mention was to also reiterate the reader. This has been an issue with the syphilis health check, overreading, or people's eyes just the same as any other test in medicine. Sometimes automating things that are visual will help, but the training, of course, still overcomes a lot of that overreading. But this one, as you will see, there's the reader, and it gives you precisely the answer: HIV non-reactive, reactive, treponemal, non-reactive, reactive, or invalid. So it just removes that the visual or human aspect of that test. So just to talk a little bit about my experience, first of all, the settings in which I've used the test. I've been the medical director of the LSU Crescent Care Sexual Health Center and the City of New Orleans Delgado STD clinic prior to the hurricane. And we have used this test 3,500 tests a month for over the last 12 years. And I think actually this, like Dr. Thorpe, maybe this may not be the final. I'll see if some pictures are there at the end, and I think they may be. But anyways, so we've used it in those two clinics for a long time, and then our Office of Public Health clinics, we've used the test, as well as we implemented a prenatal program at one point as a pilot to try to get women or to detect or discover women with syphilis whenever they would present for care, even if it was not for labor and delivery. If they had an issue with dysuria or whatever, at that point they presented for care, we would go ahead and test them in the prenatal unit. And then community health fairs, we've had a lot of experience with. So other settings, though, to consider are that in women who've had no prenatal care or who have had no syphilis testing throughout their pregnancy, this is a great time if they've delivered and they're going to be discharged on a time at which those results are not available. It could be a Friday, it could be a weekend, or even a day of the week when the lab is just not able to perform the test. At least you'll have a positive, or you'll know whether this syphilis health check or rapid syphilis test is positive. And that alone will at least help to stop the discharge, so we don't have to go and try to find the baby and find the mother after they're gone. The others are correction facilities are another great place because a lot of people have implemented screening programs upon entry into corrections facilities. But if you have drawn blood for syphilis serology and that person gets bonded out prior to the result coming back, then you're left again with potentially not being able to find that person to treat them. So emergency departments, substance use treatment programs, outreach activities, community-based, and as well as rural communities and shelters, this will be extremely helpful in those settings. With regards to the populations who we've interacted with, clinics and other settings that may be the only point of care where a person is going to touch the healthcare system. And so at that point, it's great to use that test as well. So you don't have to try to find that individual, and often very unsuccessfully. And it really helps our DIS, which I'll talk about in just a moment. Also, the decreased need for phlebotomy is huge. You will only need to now perform phlebotomy on patients who have had syphilis in the past. Other things to consider, I've mentioned already the delivery. Also, persons who are not engaged in healthcare at all, those with limited access, and then geographic areas where syphilis is spreading rapidly. Positive experiences, though, with the test for the patients and clients, they're also very satisfied. For one, their same day test results. The other is that they're just the ease of performing this test, and they just love having those same day results. And of course, no phlebotomy as well. Then for clinic staff and DIS staff satisfaction, the clinic flow, having those same results available and being able to treat that patient that day is very satisfying. As well as the decreased need for phlebotomy, especially if you have a difficult stick. It really slows down the entire clinic flow if you're just having to try to re-stick patients that are just difficult to obtain their blood from. Also, as we mentioned, for DIS, it really helps to not have that to free them up to take care of other cases where now they know that this person is syphilis and has syphilis in the clinic, and they don't have to go and find them. And it helps to rapidly put into place partner services as well. And the last that we've had experience with is a supply chain issue that occurred that was associated with COVID. And I'll talk about that in just a moment. All righty. In setting up the program, if you're considering setting up a screening program, these are some of the challenges. Will have to work out how to implement it, how to put it into your clinic flow. The EHR will need to be modified to have that order placed there. The billing considerations, which we'll talk about later on as we answer questions. Then collaboration, there's a great opportunity for collaborating. It's a combination of the DIS. We mentioned you have to have a lab with a CLIA license. In addition, you get to also have all the training that's necessary. That will increase the staff confidence, as well as decreasing the false positivity rates, as we've talked about. They will have to be trained to do controls. The CLIA lab, that they're associated with, will have to still obtain logs with control information on that and temperature control, et cetera. The other is the opportunity, the community setting. Then you plan an outreach, but it's important to plan which location should you use at which events. Once again, the training helps considerably. The collaboration is a great opportunity to collaborate with the health department and make sure that you have referrals in place for when you have a positive result, what your next step is going to be. All of that has to be in place when you're planning a community activity. So these are a couple of our examples. At a church, we had an outreach activity, health fair. We actually, in this case, collaborated with the DIS. Well, first of all, the wellness committee at that church. Then we had the DIS to actually assist with canvassing the neighborhood the day before. This picture has about 5 DIS staff people and also about a few of the members from the church who went around, and the flyers that were handed out. Then to the right, there was registration on the day of the event. We had registration inside the church. We had also combined it with flu vaccine at the time. And then the care van you see here is a Crescent Care van that we collaborated with. This van it was used only for HIV testing for a long time. Then we were able to implement rapid syphilis screening and also submission or actually screening for gonorrhea, chlamydia, and/or trichomonas that we were able to have patients collect urine or clients collect urine in the van as well. And then another event was a No AIDS Task Force walk that happens annually. And we had the Crescent Care, or the care van you can see in the background, was used at that time. And so just to look at the point of care supply chain difficulties that helped us to resolve. In the health department clinics in Louisiana from December 21 to March 22, we had limited use for pregnant women when positive pregnancy tests were discovered in clinic. We also had collaboration with community-based organizations that the health department provided tests for. But overall, we had a little bit of a pullback from widespread use initially due to some of the false positivity, but then went ahead and implemented it again. So before the supply chain issues, 9,500 or 9,582 patients had the panel done. 6,246 had phlebotomy and lab testing as a part of that. So only 65% were screened for syphilis. Then we expanded the rollout once tubes became unavailable and limited availability. Then from May to August of 22, we expanded it to all clinics. Over 9,400 patients had the panel done at that point in time. 8,355 patients had rapid syphilis tests then. Of those, and those with the previous history still had phlebotomy testing done. So with the implementation or widespread expansion, then 88% of patients were actually screened for syphilis. And so we have now then continued the point of care testing in the clinics. And so just to summarize, I've had an excellent experience and satisfaction with the point of care test, even considering the challenges, as we mentioned, that can be overcome with training. We've had an increased screening in the clinics, the same day testing, and of course, treatment cannot be mentioned enough. And then the opportunity to engage with the community and to other community-based organizations, and also to combine with things like flu vaccine and even like checking glucose, et cetera. Because with the van, we had different things happening in the van. So it wasn't like someone said, oh, that person's going in the van, they're going to get a syphilis test. No, you can combine it and make it a generalized screening for other items as well. And then the great opportunity to expand testing beyond the clinic. And then ability to combine the HIV test now with syphilis screening is very exciting. So thank you very much for your attention, and we'll be happy to answer questions as we go into that section of this webinar.
Thank you so much, Dr. Taylor. That was a fantastic overview, and you have so much experience in this space. We're so grateful to have you here to share that. I personally am having a little bit of envy about those huge plush STIs that you guys had at that walk. I've only seen the smaller versions of them, so we're gonna have to talk about how I can get one of those. All right, we're gonna shift gears really quickly and talk about some best practices for using the 2.4 million unit bicillin injections. But first, we have a couple of audience response questions. So let us see. Damon, fire away. So, true or false? There is broad availability of benzathine penicillin 2.4 million unit doses, so we can now move away from doxycycline as the treatment in non-pregnant persons. Is that true or false? We've been on a real roller coaster ride in the country over the last year around treating syphilis, and thanks to the work of the task force and so many of our partners, we have had great opportunities to continue to treat syphilis with different things. So what did people say about this? Oh, wow. So this is actually true. We are now fully available. Pfizer has worked so hard to get the backlog filled up. 2.4 million doses are ready for you to order. So it's available. You can shift away from using doxy as an alternative treatment, and non-pregnant persons, it's still reasonable in someone who's penicillin allergic, but in your routine syphilis testing and treatment, there is lots of bicillin in the world today. Next slide. So with respect to accessing the treatment of syphilis with benzathine penicillin, which reflects your current state. So no worries or concerns, you're getting your orders filled. You can only get 2.4, but you get all that you need. A lot of clinicians in the past have preferred 1.2s and giving 2 doses. We're still not getting complete orders, or they're delayed. Someone other than your supplier might be limiting your stock. Or honestly, you just order the treatment and the patient gets treated, and beyond that, you have no idea. That would reflect my reality in the clinic. I don't order, so I don't necessarily know what's happening in the background. But if you know what's happening in the background, what's your experience been? Let's see what people said, Damon. Excellent. Okay, so we've got 60% of people, no worries or concerns. That's great. I would like that to be 100%, but 20% of you are like me and you just don't know because somebody else orders it. So that's fantastic. 10% of you are having trouble getting orders. 6% someone else is delaying your stock. So in the chat, we're going to put a website you can go to. We want to hear from you. If you're having trouble getting Bicillin orders filled, that's really good information for us. And we want to hear from you. So please reach out through that contact. All right, I think we've got one more audience response question. Is that right? Oh, no, we'll come to that one later. I'm sorry, Damon, that was my fault. Best practices. What we have heard on the task force and sort of anecdotally in the field is that there's a lot of anxiety in some clinical settings with ordering the 2.4 million units or giving the 2.4 million units because of the dose is larger. And so while some clinics do it all the time and they don't worry about it, others are really used to using the 1.2 and giving 2 doses. So we went out and we looked at best practices and we looked at the literature and the safety data and what nursing journals were recommending around these injections. And we've put together just some guidance for you to help you work through some of this challenge. So one of the things you can do if you're one of those clinics that your staff are really not loving the 2.4 million units, acknowledge people's anxiety, reassure them, use some relaxation techniques. Those things seem obvious, but sometimes in a busy clinic, we forget to do them. You can warm the dose a little bit prior to injection, shake the contents, roll it between your hands for a few minutes, and that makes it less painful. What a lot of clinics do is they still just divide the dose into 2 doses and they give 2 smaller injections. And then you want to inject the medicine slowly, not in just one big rapid push. The other thing we learned about is that you can give the dose while the patient's actually laying prone on the exam table. That really helps that muscle relax. You can also have them put their weight on their other leg so that the leg you're injecting doesn't hold as much of the tension, and then have them walk around after the injection. We tend to keep people in the clinic to watch for any reactions. That's a great chance to just ask them to march in place or pace around their room or do something like that. Okay, with that, we are going to shift over. We had a couple of clinical scenarios we wanted to share with you, but we are down to the last 15 minutes. And I want to make sure that your amazing questions get answered. There are so many fantastic questions in here. So I'm going to ask Dr. Thorpe and Dr. Taylor to come back on screen. And we are going to start answering your questions. Let's see. Okay, so we'll start with Dr. Thorpe. Were there any questions in there that you saw come through that you wanted to be absolutely sure that you got answered?
There are a lot of good questions. It was hard for me to choose one.
Okay,
Great.
fair enough.
Fair enough. Questions.
Dr. Taylor, anything you wanted to make sure we got to first thing?
Yeah, I wanted to make sure that we discussed, there were a couple of questions about the use of the test in pregnant women and overtreatment, which I thought was something, some good points for us to all hear about. One, with regards to pregnant women, yes, approved for use in pregnant people. And then with regards to the overtreatment, there's always going to be a potential for overtreatment, but then the risk and benefits need to be weighed. And if there's absolutely a risk that this could be a woman who could potentially have a baby with congenital syphilis, it's worth the overtreatment. So that is just one way to think about the overtreatment. There will be some overtreatment, but it's to the advantage of being able to control syphilis.
Fantastic, thank you. So I saw that you had flagged those. Phoebe, I think I saw in the chat a question that you had answered, but I think is a really important one, and that Stephanie also wanted to weigh in on around reporting. What do we do around reporting these point of care tasks? Can you touch on that?
That's a great question. And it's a very interesting one because we have.
Oops.
Oh, sorry. Am I muted now? Okay, great. Sorry, that is a great question. In particular, because we have heard different responses to whether they want state health departments want the point of care tests reported. Some say they don't even want the point of care test reported to them, which I was very surprised at. Others say if they provide the test kit to the person doing the test, then in that case, they do want the test results reported. And the other option is also been heard. We want everything reported. So you'll notice in the guidance, we made it, there's a line about please work with your health department about meeting their expectations and reviewing what is required reporting for the test results. That was designed to create some flexibility depending on what the program wanted.
Thank you. Stephanie, anything you want to add to that?
No, that's perfectly, I agree 100% with those options.
Awesome. So I see some questions in the chat around cost and paying for this. Stephanie, since you've got some real life experience in the field doing this, what's your experience been with the cost of this test compared to traditional tests, and how do you get things paid for?
Well, the cost, of course, is going to be higher than most of the traditional tests, especially, just a point of care test. Most of them, both of them just coming on the market, et cetera. But the test pricing has gone down tremendously as time has gone on, as with regards to the syphilis health check, that is. The most recent quote is $10 per test. That is still high compared to, like a stat RPR, of course. But it's all in what you are trying to, what you're trying to promote, what you're trying to accomplish. There is reimbursement for these tests, and I'm sorry, I don't know the ChemBio price at the moment. But we are in discussions with that company as well, because that dual test is in certain situations, certain screening programs that just would work beautifully. So we'll know more about that price later. So I don't know about the ChemBio pricing, but they are reimbursed for. Currently, the reimbursement, at least for syphilis health check, is about $14, and that has come down a bit over time, but that's what it is currently.
Yeah, so again, you want to make sure you talk to your payers and understand what is covered and at what rate for your payers, knowing that different people contract for different rates. So important that you check in on your own clinical situation. Phoebe, did you want to add something else?
The ChemBio one was running around 25 per test, and that includes both the reader, and they encourage a lot of testing to make sure that the test is being read correctly. So that cost is kind of factored into that.
And there are also some grants out there. I know that in North Carolina, the public health is offering these tests if you are willing to track your results and to give some feedback on what you're seeing. So depending on what state you're in, you might want to reach out to your public health to see if they have some grant programs that can help support you. Dr. Taylor, did you want to add something else?
Yes, someone asked about the public health pricing as well. And so, yes, Syphilis Health Check has worked with us on public health pricing, and I have not had the opportunity to speak with ChemBio about that, but I'm sure that they're doing the same.
Fantastic. This is, of course, like a critical part of this process, right? No money, no mission. You can't do everything you want to do if you don't have a way to pay for it. So I'm glad that we got to talk about that. I do see a lot of questions kind of in the vein of how do you decide when you treat somebody with this test without having your confirmatory versus when do you wait for the confirmatory to treat them? And I think it's a really good question. It could be on the side of you don't want to overtreat people that don't actually need the test because it's a false positive or there's another reason for it, versus do you lose someone to follow up and you miss that window of opportunity? So maybe Dr. Taylor, could you share with your clinical experience when you would decide to go on and treat somebody versus when you decide to wait for a confirmatory test?
Right, of course. Well, of course, anyone who has had a partner with syphilis, of course, would treat them that day. But there are individuals and patients who just said, I want to wait until I get the other test results before I get treated. And then it comes down to clinical judgment. Whether is this somebody that you think think they're reliable and that they're going to come back for treatment, or is it someone that you think you may not ever see them again? And so that's really what it comes down to. and how high is their risk for having the infection that day. And and patients realize, oh, I had gonorrhea last week. Now I have a positive syphilis health check. Yes, it's quite likely that I'm going to have syphilis. So it boils down to those types of clinical judgments.
I think that's exactly right. And also going back to that contact, if someone's a contact to syphilis, even if you don't have that confirmed, maybe you can't get DIS on the phone. But if they tell me that they are a contact to syphilis and they've come into the office for that, I am going to treat them. There was a time when I might say, well, let me get those lab results because we really don't see much syphilis. I'm going to be sure. Now, man, if somebody says that word, they're getting treated because there's just so much of it out there. So contacts, go on and treat them. What about false positives? I see a few questions in the chat around what would cause a false positive point of care test. Any experience with that and what clinical settings you might see that in?
We definitely see them less than, we talk about biologic false positives with RPRs, VDRLs, definitely less and almost eliminated. Probably the most common cause or reason for a false positive is an overreading of the line. And that is where the training comes into play. That will greatly reduce the false positives. Now, there are some individuals who have, I don't know if there's necessarily a list of these are the things that interfere with this test and cause false positive, but we have had a few individuals with like liver issues or whatever that will have a positive test. And we currently have a positive test and a negative serology. We know then that something is interfering, but I don't know what it is, but it doesn't happen a lot.
Fantastic. And I see a really practical question that I don't know the answer to, and you may not to either, but are the reagents of the rapid test degraded by heat? So when you're going out and you're doing field outreach in hot summer days, do you have to do anything special with the test, or how should that be thought about?
That's a temperature that they need to be maintained at. And so, yes, you do have your nice little cooler going out into the community or to the health fair or whatever. Yes, they are temperature controlled.
And the manufacturer suggests if you're testing out in hot conditions that you intermittently run test controls to ensure that the results are being accurate.
Fantastic.
So there's a way to control for it.
Yep, that makes a lot of sense. And having done a lot of clinica in the fields, it does get awfully hot out there with all of your equipment. So all right, before we shift to our last few closing slides, I just want to make sure that there weren't any questions out there that you saw that you wanted to make sure you answered before we shifted gears to our last few slides. And I know it's hard to answer questions and look at them at the same time, but yeah.
There was one that talked about treatment in the field and whether there should be a rapid pregnancy test to go along with that. So treatment in the field is something that unless, we really like to have that in a controlled, like we wouldn't in a van or a health fair say, okay, come on and here's your screening, you're positive, get your treatment. We wouldn't handle that like that in the field. We do have a shot program. We call it a shot program. It's syphilis home observed therapy or treatment, and our nurses go out, or a nurse and a DIS go out as a dual team, and we'll treat for women who have no way to get back into clinic or anything like that. But there's no general recommendation, chase everybody down with Bicilla. You wish you could, but we can't.
Yeah, and I think I've seen Louisiana's protocol. They have done some amazing work with this home delivered treatment, and different health departments do that. They send nurses into the field, but with really pretty strict protocols as how you observe somebody, and do you have access, to a cell service to call 911 if someone has an anaphylaxis reaction. There's a lot of tricks to doing this in the field. Yeah. Fantastic. All right. Well, with that, I will pull up our last few slides. And we have one final poll question that I will ask Damon to see if he can fire, that I tried to give you out of order. The following interventions would help all of us get ahead of congenital syphilis cases. Testing women in pregnancy at the first prenatal visit between 28 and 30 weeks and at delivery. Supporting partner testing and treatment. Increasing the use of doxypep in non-pregnant persons who meet the criteria. Testing people who present to urgent cares and emergency departments with STI symptoms, or all of the above. Which is the right answer for how we can all get ahead of congenital syphilis? Let's see what folks said, Damon. I knew you were a smart group. Yes, we have so many things that we can be doing together to get ahead of syphilis. I've been doing some work on a presentation later in the week with an international audience, and it looks like every country I looked up is having a syphilis outbreak. So it's not just us in the United States, but we have got a lot of work to do together. Being here is one of the first steps in getting us ahead of things. And coming up, let's see, I think I just went ahead too fast. There we go. Coming up, we've got 4 more sessions in our Summer Syphilis series. The next one is around correctional facilities and best practices. And so you might be thinking, I don't need to go to that one. I don't work in a correctional setting. But actually, I would encourage you to attend this one. It's going to have some really good ideas that you can translate into other environments. And also, if you're clinical, you see people who have recently been in correctional facilities. And so it'd be helpful to have that insight. Then we're going to talk about doxycycline as prevention and treatment. And we'll move into the last 2 after that. So please keep these on your radar. Great information coming to you. Also, this is a list of resources that we shared at our last. It's links to a CDC website that's got tremendous syphilis resources, but you can scan this QR code and get to those resources in case you're looking for some additional information. And then finally, for more information, or if you've got questions or feedback for us, by the way, I saw lots of feedback in there that you'd like recordings of these webinars made available. So we're taking that into consideration. Thank you for that feedback. There's an email address you can send things to us at, and we will respond to you. And then also we have that STD shortages at CDC.gov email address. If you're having trouble accessing Bicillin, and not just accessing 1.2. We know that we're not completely up on the 1.2s, but there should be abundant 2.4 out there in the world. If you're having trouble accessing it, we really want to hear from you about it. So please send an email so that we can track that down and understand what's going on in your region and in your community. And with that, thank you so much for spending the lunch hour with us, or for some of you, it may be your breakfast hour, depending on what part of the country you're in. Thank you so much to Dr. Taylor and Dr. Thorpe for your expertise and your commitment to this work, and for everyone from the task force that has made all this possible. Thanks so much, everybody. Have a fantastic day.